All right. Well, welcome back, everybody, to another fantastic Friday. We're having a little weather here in New York, but I am sure it will be an absolutely fantastic conversation that we're going to have today. Welcome back to Women's Health Weekly, brought to you by the experts in women's healthcare at Maiden Lane Medical. The goal of this conversation that we like to have with YouTube viewers, YouTube audience on a weekly basis is that we want to bring to you information directly from the experts so that you don't have to go out on the internet and look for things that may be misleading or may not be true or may be geared towards selling products. We want to offer you the best expert information. It just so happens that this is like the perfect storm of two things today, other than the rain. The perfect storm of two things today. First, it's Fibroids Awareness Month, and we're going to talk all about fibroids today. Second, at Maiden Lane Medical, we have like 5 or 6 gynecologists who are absolute experts in fibroids, who have dedicated their careers to working with women who have fibroids, working with infertility doctors and general gynecologists and obstetricians, and we are truly the region's experts in this area. So I am very happy to bring one of our other physicians and gynecologic surgeons here on the weekly program with us. And I know you've all met her before. Some of you may be her patients. You've all met Dr. Shoma Datta. Dr. Datta has been with the practice for many years and is an expert in minimally invasive surgery, gynecology, and has a particular interest in fibroids. So Dr. Datta, did I leave anything out from the introduction about how amazing you are?
Oh, do go on. No, thank you very much. This is obviously at Maiden Lane one of our bread and butter topics, and it affects so many patients. And I think we really do have a really a great program on management of this issue. So I'm thrilled to talk about this today.
Yeah, this is going to be a fun conversation with us for us today because it really flows. This is not a. This is something we do every day. We do it all day. We have a ton of referrals from physicians in the community and even around the country and the world for managing some of the complex issues associated with this topic. Before we continue, just want to add 2 items. One, we have no commercial interests. We don't sell products on this show. We don't make any money from doing this show. We don't have any sponsors on Facebook or YouTube. It doesn't work that way. This is really us giving our time because we want to get information out there. The second thing is we of course want to promote our broadcasts. So in doing that, I'm going to promote 2 items. Please subscribe to our YouTube channel, and please go ahead and visit our podcast, which is available on Apple Podcasts and Spotify, and there's some Google Podcasts. There are about 10 other platforms that have picked up our podcast, and we're really excited to be able to offer that information on a podcast as well. And the last thing before we get going is please ask us questions. If you're on this show with us, we're on YouTube. We want to hear from you. We want to hear your questions. We want to hear your concerns. We want to hear what you think of what we're saying, and we're happy to entertain all of that and work it into our program. All right, Dr. Datta, ready to rock?
I'm ready.
You are ready. You are always ready. That's what's awesome about you. Okay, so all right, let's start with the basics. What on earth is what's Levy even talking about? What is a fibroid?
Okay, so I can chime in. Basically, a fibroid.
I was giving that to you. I was gonna let you. I was gonna let you. I was gonna give that.
All right, I'll take the alley-oop there. Yeah, I'll take the alley-oop. So essentially what a fibroid is, if you think about the uterus, it's basically a large, very muscular structure for the purposes of pregnancy and going on to delivery. What the fibroid is, it's a benign tumor, number one, meaning not a cancer, but it is an overgrowth of some cells, and it's an overgrowth of muscular tissue within the uterus. And it can be on several aspects of the uterus. It can be, and this is very important, you'll notice down the road when we talk about treatment, it can be sitting on top of the fibroid, it can be at different depths within the wall of the fibroid, and it can even be impinging on that inner part of the cavity where you typically would carry a pregnancy. So location is very important, and that's the gist of what exactly a fibroid is. Because a lot of women actually, a lot of patients say, "Oh, I saw on my sonogram," or somebody told me in the past I had fibroids, but what exactly is it? So that's a good kind of basic explanation.
So the fibroids are actually, right, as you said, made of tissue that is in the muscular part of the uterus. There are two parts to that muscular part, right? There's the actual muscle cells, and then there's the stroma, which is the stuff that fills in. And fibroids kind of are mainly associated with that stromal portion, which has a very different level of hormonal activity for estrogen receptors in particular. One thing to add about fibroids while I'm on the topic of estrogen is that it's an estrogen responsive tumor, right? It's a benign estrogen responsive tumor. So a lot of we could weave that theme into a lot of the conversation when we talk about who gets it, why people get it, and some of the ways in which we potentially treat it. It's an estrogen responsive tumor. The basics of it are more estrogen, bigger tumor, or bigger, more tumors, and the basics are on the opposite side are less estrogen, smaller tumors. That doesn't always work out perfectly, but it's a general theme. Okay, so how does a woman know if she has fibroids? What are the signs or the symptoms that a patient might start complaining about when there might possibly be fibroids?
So typically what we see in the office, most commonly women come in and they're noticed heavier periods, heavy bleeding outside the time of the period, or random spotting, just anything outside of the normal pattern of a monthly period. And in addition, they may have a number of other symptoms as well. One of them related to bulk symptoms. So because there is now this, tumor of any different size, but it could be putting pressure on the bladder, pelvic pressure in general, maybe with intercourse feeling extra pressure, so there could be some pressure pain that way, could be extra cramping feeling, and then in general a lot of women say all of a sudden another thing can be bladder pressure. I feel like I have to run to the bathroom to empty my bladder much more often than before. There's even sometimes it can put compression on the rectum, so maybe difficulty passing a bowel movement, or feeling that constant pressure. Those are what we most commonly see. Sometimes farther down the road, they may come in and say, you know what, my doctor told me I'm anemic. My blood count is very low, and we're looking for reasons why. And I've noticed my periods are heavy. So does that have something to do with it? It really has a pretty big spectrum of symptoms that we see. But I would say irregular bleeding is probably the first thing that we notice.
Yeah, you're right. Irregular bleeding is probably the most common thing we see. But what's really important about this conversation about symptoms is that there are a lot of symptoms that can both be directly related to fibroids, but also related to other things in the absence of fibroids. And one of the things that has the potential to be a little bit more difficult, which is why you should always follow up with your gynecologist for these issues, is that you can have fibroids and abnormal bleeding, but the abnormal bleeding has nothing to do with the fibroids. I saw a patient like that exactly yesterday, and there was a whole separate issue that needed to be addressed. So some of these issues, some women come in with painful intercourse because the uterus is tender, and painful intercourse can be a sign of fibroids, but it's far down on the list of common things that we see in association with fibroids. And I think the takeaway from what Dr. Datta said was really the point of going to see a gynecologist when there's a change. When there's a change in your bleeding pattern, normally indicates or typically indicates that there's potentially a problem. I want to go back to what you said earlier, just while we're on the basics, before we kind of move on to some of these awesome fibroid-related questions coming through from our YouTube viewers. Just kind of the basics on the locations, right? If you think of the uterus as a big muscular ball, and you think of that ball as having smaller balls associated with it, then you could get an idea of where fibroids might potentially be located. Some fibroids are balls on the outside of the bigger ball. Some fibroids are fibroids on the very inside or the cavity of the bigger ball. and sometimes fibroids can be associated um, with inside the wall or in that or in or in what makes up the bigger ball. So there are some definite sorry about that. There are some definite things to understand about the locations of the fibroids as we continue this conversation. So I have a great question or a quick question from one of our YouTube viewers. Sean asks, can there also be hip pain associated with fibroids? And I'll kind of take that. Sure, there can be hip pain associated with fibroids. Fibroids can get large enough to do two things. I think we lost Dr. Datta-Thomas's camera there. Fibroids can, oh, there you are. Hi. Fibroids can get large enough to do two things, Sean. One thing fibroids can get large enough to do is push on the pelvic floor muscles. And sometimes when they push on pelvic floor muscles, they change the way those muscles attach throughout the pelvis and at the hip, and that in and of itself can cause hip pain. If you have radiating pain throughout your buttocks and into your hip and even potentially down your legs on one side, most commonly, then it's entirely possible that those fibroids have pushed on some of the nerve roots coming out of your lower spine. And that's a sign of something a little more advanced and something that that can probably be alleviated and treated quite easily. So that's another potential sign that a patient might show up with if they have fibroids. Let me get to, I have some great questions on here about treating and preventing fibroids. We're going to get to that. Let me get to the C word. The C word, the cancer word. Can fibroids be, you said fibroids are benign tumors. Can fibroids be cancer?
So when we're talking about an existing fibroid, it is extremely rare that we're dealing with something. The concern oftentimes that my patients will have is this something that can become cancer? And the answer is it's extremely rare, almost approaching less than 0.5%, that something that exists will have a cancerous transformation.
So yeah, they tend not to become cancer. That's more likely that they started off as cancer and then just kind of grew, and someone thought it was a fibroid, and it was really just a cancer to start off with, and it kind of grew and started to look like a fibroid, but it really wasn't. So fibroids in and of themselves are benign tumors, and there are some ways to potentially decide whether or not there's a cancer there based on the imaging results of an MRI. There's one particular laboratory study that can be done, and that is one potential way to look at it. All right, so let's talk about preventing fibroids, how they grow. Can fibroids even be prevented? Is there anything someone can do to prevent fibroids?
Typically, at this point, we don't have a lot of great preventive methods. There is some, loose data on low-fat diet, and again, we do see that the fibroid is hormone dependent, like we mentioned. So there is some thought about, can something be accelerated with hormone supplementation or medication? But there's not really a standard practice that we can offer to completely prevent fibroids across the board.
Yeah, there isn't anything out there really. Cedra asked a really great question about green tea, and there is some evidence. The specific question that Cedra asked was, does green tea help alleviate growth and size? And she actually couched it in a very reasonable way, because there's no evidence that green tea prevents fibroids. But the question is very reasonable, because there is something in green tea called a catechin. That's a class of compounds that are found in a lot of teas and in other natural and herbal supplementations that generally reduce inflammation. And one of the reasons fibroids bother you, not me, I don't have fibroids, but for women who have fibroids, one of the reasons they're bothersome is because they're surrounded by a highly inflammatory environment. And it's also part of the reason they cause bleeding disruptions. So if you have this inflammatory environment around a fibroid and you can decrease it, then they're less likely to bother you. So women walk around with fibroids all the time that are totally asymptomatic. They have no problems with them, and probably because their inflammatory response is different from somebody else's inflammatory response, or the fibroids are different size or different location. But it's a very good question about the green tea and the fibroids, and it makes a lot of sense. Remember that abnormal bleeding in the uterus it comes from like two main areas, right? It comes from an anatomic problem, whether it's a fibroid or a polyp, and it comes from an inflammatory environment. So if you have an inflammatory environment in the uterus and you decrease that inflammatory environment, then if there was abnormal bleeding associated with that inflammatory environment, then decreasing inflammation is likely to improve that bleeding profile. And it's interesting, people always ask me the question, as a side note, we often give anti-inflammatory medications such as Motrin to women who have a newly placed IUD and are having some, at the very beginning, persistent bleeding. And the main reason for that persistent bleeding is because the IUD has now induced a significant amount of inflammation, and we can cut it down with some low dose anti-inflammatory. So that's and people say, well, I thought Motrin thins your blood. I should bleed more, but the uterine vessels just don't work that way. It's a whole different mechanism of action of stopping bleeding from the tiny uterine vessels than it is in the rest of the body. It's less platelet dependent than it is inflammation dependent. So okay, I don't want to get off topic, but that's inflammation is associated with a lot of diseases. As you're probably all hearing on the news about COVID-19, how important inflammation is in our bodies, and fibroids are no exception to that. Okay. So before we get off the cancer topic, we'll completely leave it behind. There was controversy many, many years ago about a particular technique used to remove fibroids from the body, and that technique was called morcellation. Sadly, a woman in Boston had fibroids. She was a young woman, I believe a young mother, and had the procedure, and a device called a morcellator was used. And it wound up the fibroid turned out to be cancer, which, as Dr. Datta said, is pretty rare. So the doctors didn't really have a way to clearly ahead of time deny it. They presumed, as they probably should have, that this was fibroids. And what they wound up doing with this morcellator was spreading little chips of fibroids all over her belly and making her cancer much more severe. And I believe she passed away as a result of that. So that was a very sad story that got us into a movement of not using morcellators anymore. So now we have a whole different way of taking them out. So it is important to do our best to know ahead of time if there's cancer, but we've eliminated that morcellator problem, so we don't spread cancer around people's bellies anymore. Okay, Dr. Dunn, I'm sorry, go ahead.
Brought that up, Ken, if you don't mind just tagging on. I think that's a really important discussion that I'm very impressed. A lot of patients are coming forward and asking, so how are you going to remove this fibroid? I hear that, there's this story about spreading cancer. And I think it just goes to show that it is important to have the discussion with your gynecologist and your surgeon about the techniques that they use, and that they have a variety of tools in the toolbox. In terms of medical therapy, surgical therapy, and that's why I love telecasts like this and information to get out there, because I do think the patient and doctor should be on an even level with the conversation. And these type of questions, especially for fibroid surgery, are extremely important. We've seen since that morcellation issue that we've really had to pivot, and we've been lucky to all. We have 4 or 5 of us in our practice that do this surgery, and we often have kind of gotten tips and tricks from each other on how to evolve this technique to make it something really safe. And I think it's been very effective. I think the literature is showing that the risk of spreading the cancer is not as high as we initially thought when we use these more focused techniques where we're not spreading specimen. But to your point, I'm so glad you brought that up, because I do think that's an important discussion for the patient to have with their surgeon.
Yeah, it's definitely an important discussion to have ahead of time. And interestingly enough, on the side note with regard to that, once we stopped using the morcelator, the length of our surgeries actually decreased. It wasn't, as it turns out, it wasn't faster. It wasn't a faster way to get it out. We just made a tiny extra, like 1 centimeter incision in the belly button, put it in a bag, and now we cut it out from the bag, and that whole process usually takes like 7 minutes. So it goes
Yeah.
really, versus the morcelator that took like a half hour and broke down all the time. Things you know now that go on in the operating room are to our YouTube friends. There are two great questions that are on here about risk of getting fibroids and what can be done additionally to kind of decrease growth. But I want to, before I address that, I'd really like to go to what we kind of skipped over, which is who gets fibroids, and a lot of that answer is really in the just general epidemiology of fibroids. So who are the people that genetically are most likely to get fibroids?
So it's really interesting. The estimate in general in the total population is all the way possibly up to 80% of women that do have fibroids at some point. We do see that by age 35, and then again when we compare at age 50, that African American women compared to Caucasian women do have a higher propensity for this. It's probably up to about 70 to 80% in the African American population, and more around 60% in the Caucasian based on our data. So we do see some pattern there.
So, and Hispanic women tend to get it at a similar rate that Caucasian women, but the people that get it the least often are Asian women, interestingly enough. And I think that goes along with, from an epidemiologic standpoint, the breast cancer data also. Asian women have the lowest rates of breast cancer unless they grew up in America. So Asian women who are eating Asian diets have low rates of fibroids and breast cancer. Asian women who are eating American diets have high rates of breast cancer. And by American diets, I mean like McDonald's in New York and McDonald's in Beijing are the same bad thing. So that's sort of what I'm talking about with regard to American diets or Western European diets. Okay. So 80% of women, up to 80% of women, have fibroids, are at risk of fibroids at some point in their lifetime. But we clearly don't see 80% of women complaining about fibroid symptoms. So it's possible to have fibroids and not even be bothered by it.
Right. Probably about 30 to 40% of those women are actually symptomatic. And as another statistic, the actual surgery that we're performing, which we'll talk about in a few moments, there's about 30,000 specific fibroid surgeries performed, myomectomies, so they're called, performed on an average year in the U.S., and about half of hysterectomies, which is close to 200,000 per year, are performed for myomas or fibroids.
Yeah, it's an incredibly common problem and an incredibly common problem, and you'd be surprised how many doctors get it wrong, which is why you need to be treated by experts in the area. All right, so just a couple of quick questions on prevention and growth and what can I do to stop it, and before we spend the rest of the show talking about treatment and potentially even effects on pregnancy. So, is there anything? Liana asks, Liana, pardon me if I've butchered your name. I apologize. Is there anything one can do to minimize the risk of getting fibroids? And I would say probably not. There are some risk factors for getting fibroids, and I'll talk about those now. One of the risk factors is obesity. And so heavier women or women with a higher body mass index tend to get fibroids at higher rates. Most people believe that's because of the extra estrogen that's produced in the peripheral fat. Remember, we said at the beginning, fibroids are an estrogen responsive disease, and more estrogen is going to make that cook along. Another risk is smoking a risk factor, as far as I know, or is it not?
I don't believe so.
You don't think? Yeah, I don't think smoking's a risk factor either. The other risk factor, actually, interestingly enough, because Sussy asked me about birth control, Sussy QW asked me about birth control, and yeah, birth control pills confer a higher risk for getting fibroids. That's not a reason not to take birth control pills if that's the best form of contraception for you. However, birth control pills do increase your risk of getting fibroids. And I don't think anyone clearly knows why. We just have the observation that there's about a 1.6 to 1.8 relative risk of getting fibroids versus people who are not on birth control pills. Okay, great. So just on a side note, while we kind of segue into treatment, just want to add in everybody that I want to welcome everyone back this week to Maiden Lane Medical's Women's Health Weekly Telecast, where expert information about women's health is brought to you by the top doctors in New York City, around the country, and around the world. Here today to talk about fibroids and Fibroid Awareness Month is myself, Dr. Levy, and Dr. Shoma Datta-Thomas. And please join us on our podcast if you can. So as a good segue into treatment, treatment modalities, Sean asked the question, are you performing surgeries now or not? I'm asking because of COVID. Good question. We're back. We are performing surgeries insofar as the hospitals in New York City will allow us to. Everybody's trying to get elective cases back onto the schedule, and somewhere in the back of everyone's head, I think they're trying to beat a second wave into the operating room and get their patients taken care of. But the operating rooms are tight. We just got our block time back at 2 different hospitals, so we're really excited. And so we're cruising along like we were prior to COVID with regard to surgical procedures. So let's talk about treatments and how do you decide what treatment to use? Because we have a lot of different treatments for fibroids. There are a lot of different modalities, from doing like nothing to doing major surgery. What are the factors, Dr. Datta-Thomas, that go into making a decision about how one would offer a particular treatment to a patient? And remember, when we talk about fibroid treatments, it's a team approach. You're our partner. This can't be done in a unilateral way. We can't dictate a treatment. We want everyone to have the best education they can have about fibroids. We want all our patients to be informed. We send patients to websites to ask questions. We really want everyone to get it, because not being informed about your options when it comes to fibroids is actually probably worse than getting like no treatment, or it's no good. It doesn't work out well for anybody. So Dr. Datta, that was sort of what I was asking you, is what are the factors? How do you approach that conversation with a patient?
Well, I like that you mentioned it could range anywhere from observation to major surgery. And I think it's important that every time we're trying to figure out a treatment plan, that we really present the range of options and pick out, along with our patient who is our partner in this, we're really picking out what's the best. I like to work a little bit backwards in that I start with what are our goals for the surgery, and
or the not surgery.
Or the not surgery. Sorry.
Right.
What are our goals for treatment? Thank you. What are our goals for treatment? And usually that will lead to a few factors. So one is, what are the symptoms that we're dealing with? Is it bleeding? Is it pressure? Is it concerns for pregnancy planning? So what are our priorities, and what are we really trying to treat at the end of the day? And then and that includes, or actually the next thing we think about is, what are we looking at in terms of you as the patient, in terms of your age, your anatomy, most importantly, and obviously for this topic, a big consideration has to be, what are the reproductive plans we have? Are we planning for pregnancy in the near future, in the far future? Are we done with pregnancy? Are we not planning to have any pregnancies at all? So that's obviously a very critical topic. And then I think it's a discussion of, okay, well, based on those initial factors, these are what's available to us. And how comfortable are we, and how big are we looking to go at this time? For me, in general, I usually say if it's something where we have time and there's not an urgency or one particular clear goal needed to be addressed at the time, I usually say let's consider the smallest and then go to the largest. I mean, we're surgeons. We're lucky to have, again, we're all surgical specialists in fibroid surgery, meaning we have extensive experience with minimally invasive surgery, but that doesn't mean that's the only option we're going to give. And oftentimes we have a lot of discussion and trial of other medical treatments if time allows and if our goals for treatment allow for that. So I think it's important to remember it's not something that we have to jump into surgery, and that really we should hear all of our options. So goals for treatment, our particular anatomy that we're dealing with, age, which ties into reproductive plans, and then how far do we want to go with treatment? How big do we want to go right now? That's kind of how I outline it when I have my discussions.
Yeah, absolutely. And those are really important factors. Obviously, other medical issues may play into it. How urgent it is, for example, with some level of regularity. Just because we're a referral office with some level of regularity, I see patients with fibroids that are large enough that they've pressed on the ureters, which are the tubes that carry the urine from the kidneys to the bladder. If we don't relieve the pressure from one or both ureters, we could, the patient then risks damaging the kidneys and could lose a kidney or both if you just do nothing. So in those cases, it's very difficult to recommend anything other than surgery to make sure we relieve that pressure in the short order. But you're right. Anything that ranges from kind of that to just observation and doing nothing are really sort of outlines our treatment options. Very often we see patients. Let's start from the kind of most radical treatment for fibroids, which is a hysterectomy, and I'm gonna go there first because Good Samaritan asked me about the idea that a couple of gynecologists that his wife saw was just get a hysterectomy. And I'm guessing the conversation was a little broader than just get a hysterectomy, but that's often a lot of the times what doctors say, and I think part of that comes from some lack of experience. If it's not someone that focuses their career solely on managing fibroids, that's a really easy thing to do, but it's not nuanced, and it's not always respectful towards the patient's wishes, and it's not always the least invasive thing to do. So let's start with that big thing. What's another kind of lesser big thing that we can do, which is a myomectomy? Now, a myomectomy is just a fancy word for taking fibroids out. And fibroids can be taken out in many, many different ways. One of the ways which we've shunned taking fibroids out is I'm going to go on my chest here, making a big abdominal incision, opening up the belly either vertically or horizontally, and removing them, leaving you in the hospital for 3 days, putting you out of work for 6 weeks as a result of that. That's not what we do. That's almost never what's recommended. I can't remember the last time that we did one of those large surgeries. It's been years and years and years. Because if we have a difficult time doing it through tiny incisions, we can always get together as a team with the doctors at Maiden Lane Medical and take care of it together. There's laparoscopic myomectomy, which is putting a couple of tiny holes in the abdominal wall and using instruments to remove the fibroids. That can be done with a regular laparoscopy. That can be done with a robotic assistance, which is our favored way of doing it. But fibroids aren't always accessible through those tiny incisions. In fact, sometimes they're just, as Dr. Datta mentioned earlier, just inside the cavity of the uterus. So it doesn't make sense to then cut through the entire uterus just to get to the cavity, when we can access that cavity in a much more clean, much nicer, minimally invasive way, which is to do surgery through the vagina, in through the cervix, and then put the camera into the uterus and cut it out from the uterus that way. And that's an incisionless, easy in and out surgery that makes a lot of sense for a lot of women. Because we get a lot of referrals from infertility doctors, that's often the problem. And it's a very simple surgery for us to do. Sometimes in the office we can do that, and sometimes we take patients to the hospital for it, really depending on the size and what type of support we'll need for that surgery. So there are other minimally invasive things that certainly can be done. One of the minimally invasive approaches that patients frequently ask me about is uterine fibroid embolization. And I have to tell you that I'm a big fan of uterine fibroid embolization. And the reason I'm a big fan of it is because it's not surgery. And it generally comes with less predictable morbidity than surgery. There's no big, you get a little sedated, but there's no intubation, there's no big anesthesia task. Yeah, you're in the hospital overnight, so what? It's a procedure in which an interventional radiologist takes a small tube and puts it in the artery in your leg and moves it all the way up into the artery near your uterus and blocks the blood flow, uses little microbeads to block the blood flow to the fibroids in the uterus. It's a great therapy, and I really like it for stopping bleeding in women who have completed childbearing in order to avoid surgery, so that you can stave off that time between symptoms and getting to menopause, which for most women will decrease or stop that bleeding altogether and significantly decrease the amount of symptoms they're having. Why did I emphasize women who have completed childbearing? Because there's a good body of data. And so no one wants to experiment on pregnant women, and pregnant women don't want to be experimented on, which is, well, on both sides is exactly how we want it. But so there's no good data on pregnancy outcomes with different anatomical variants of blood vessels around the uterus and fibroids. And the issue then becomes those microbeads go to two main places depending on the type of anatomy one has. They can go to the ovaries and decrease the quality of ovulation, and they can go to the endometrium and decrease the quality of the blood flow to the endometrium, which, by the way, is where the embryo implants at the beginning of a pregnancy. And if your endometrium is bad news, that pregnancy is not going to hold. And if it's bad news because of an embolization, that's big trouble. So we try to avoid uterine fibroid embolizations in women who have not completed their childbearing. So usually that's generally reserved for older patients. All right. So are those the main? I know there are other techniques out there which we don't necessarily use here at Maiden Lane Medical. There are two other ones that are popular, and if you read them on the internet, they're certainly out there. One of them is called MRGFUS. Which is magnetic resonance guided fibroid ultrasound. I'm pretty sure everyone's abandoned that technique at this point, mainly the reason being that it takes like 6 hours on the MR scanner getting blasted with ultrasound waves in the fibroid to just like melt a like 4 or 5 centimeter fibroid. And so that works for a very small subset of women with that like perfect smaller fibroid, but doesn't work for like 95% of women. The other one is fibroid ablation, which is a procedure done with basically an electrical wand that's placed laparoscopically and can potentially be placed under ultrasound guidance, but most commonly laparoscopically. And it's placed into the fibroid and basically burns the inside of the fibroid, right? And thus destroying the blood vessels around it, and then it kind of shrinks. So it's very similar to a uterine fibroid embolization, minus the microbeads that would go to your ovaries or endometrium. The downside of that is that you still have fibroids, and if bulk symptoms is a big problem, it certainly won't relieve those bulk symptoms quickly, and may make some pain worse, because there's a lot of inflammation associated with having that dead tissue sitting inside of your uterus. All right, so we hear this all the time, right? We hear all the time, Dr. Datta, about, I'm gonna say it. Should I say it? The L word? I'll say it. Fine. We hear about the L word all the time. Lupron. Lupron is you like that? The L word? Is there a show? Hold on, I just realized. She's laughing at me, but I just realized there's a show called the L word. I wasn't even thinking that. And the L word definitely wasn't Levy. That's for sure. right, I'm sorry about that. Okay, so yeah, there's Lupron, which isn't a drug we like to use, except in incredibly rare circumstances, in patients who have very heavy bleeding and are really anemic prior to surgery. Um, Lupron is a medication that basically shuts down the ability of your brain to talk to your ovaries and tell your ovaries to produce estrogen. So it creates a state in which you're basically in menopause. It's called medical menopause for a reason. Your estrogen levels are very low. And most fibroids will respond to those low estrogen levels, but you know what else will respond to those low estrogen levels? Your bones. So you're going to have bone loss when you're on Lupron. And that may be okay for some older women on a short term, but if you're like 25 years old and you haven't hit your peak bone mineral density, or you're 30 years old and you haven't peaked, and you're kind of getting to the point where you're hitting your peak bone mineral density, which you hit between like age 30 and 32, then Lupron's a very bad idea for you, speaking in general terms. A lot of times, gynecologists will put patients on Lupron to shrink the fibroids, which is effective. But you know what happens when you stop the Lupron? Almost 100% of the time, those fibroids come back. So there are two, right, exactly, Dr. Datta. So there are two big indications for Lupron, either to help as a bridge on the short term to maybe get you if you're close to menopause, and the other one is as a pre-surgical treatment to use in women in whom we need to correct the anemia by shutting down the menses altogether and then correcting the anemia. Of course, iron infusions and even blood transfusions work also. We get worried about bone loss so much that because you don't really ever make that bone loss up, it never comes back. The rate of growth comes back, but the bone loss is bone loss is bone loss. Okay, so we talked about what else. What else is out there? I know there's other stuff out there. I know you've got a couple of things to talk about.
Always. I think that's a great comprehensive overview. And I think just on top of that, kind of one layer to think about when you're considering or you're, discussing with your physician, hysterectomy, myomectomy, or other procedures. When we, I just want to clarify, when we say if you're done with reproductive years, then hysterectomies can be considered, or, based on your future plans. I think we are seeing a bit of a trend towards double thinking, like why are we going to hysterectomy directly when maybe we can actually resolve this just by removing the fibroid. I think as surgical techniques have evolved and experts are focusing on this, we're seeing that hysterectomy was once offered as first-line treatment for fibroids. And again, with the statistics that I said, about half of hysterectomies performed annually are for fibroids. That's almost 200,000. And then there's 30,000 specifically myomectomy. So that's a lot of surgery we're doing for fibroids. And I think we're noticing now the trend is, organ conservation, meaning uterine preservation, may be something that's a very important discussion even beyond childbearing years. And sometimes, it's worth talking about, even if it's just a comfort level as a patient. Well, why do I have to, have the uterus removed? What's the benefit of removing it, and what's the con of keeping it? One common thing that comes up is, well, if we remove your uterus and we leave the ovaries, then there's really no difference. But what we're seeing is that's not really true. There is earlier menopause seen in women who have hysterectomy, even if the ovaries are preserved, when compared to
right. That's a great point. And I was actually whipping out my calculator to calculate that, because I don't remember it off the top of my head how many women years of hormone production are lost due to hysterectomy without oophorectomy. Because on average, women who've had a hysterectomy but not had their ovaries out will go into that ovarian menopause like 6 or 7 months earlier.
Yep.
So if you think about it, if you've done like 200,000 hysterectomies and you multiply that, that's like millions of women years of good hormone production lost. And we want you to have that good hormone production, because We want to decrease things like Alzheimer's and heart disease and hypercholesterolemia and things that will kill you later in life that you may not recognize missing in those, that may not cause a problem in the 6 months where you didn't have that great hormone production. I want to walk down the rest of the chain of treatments. We talked about the last thing I talked about was Lupron. There are other medical treatments. Some of the things out there are a class of drugs called the selective progesterone receptor modulators. Those can and have proven to be somewhat effective, but again, are medical therapies. And if you stop them, the fibroids and bleeding will come right back. There's another class of medications called mifepristone, the RU486 you may have heard about. We don't really use that often, although it can potentially be effective therapy. And they're certainly doing nothing. If you don't have significant symptoms or you can live with your symptoms, then do nothing. That's always the safest treatment. Patients ask about birth control pills very frequently, and again, we don't really recommend that because there is data that suggests that birth control pills can make fibroids themselves worse. Big broad picture, if there are bleeding problems that are the only problem, then it's unlikely that surgery is necessary. Often that can be managed with even a hormone-containing IUD. Progesterone is a great medication by itself to treat bleeding associated with fibroids. All right, I want to get to some of these awesome YouTube viewer questions as we kind of get towards the end here. Liana asked another great question. Are polyps a type of fibroids? And I wanted to actually address that earlier. Patients come in asking about polyps and thinking they have fibroids. Polyps, Liana, are not fibroids. Polyps are a whole different story. Polyps are an overgrowth of the lining of the uterus, the endometrium. Patients come in also sometimes confused about cysts. They were told they had a cyst. And often cysts are in the ovaries, so cysts aren't fibroids, but certain types of ovarian cysts can have fibrotic type tissue in it, the fibrothecomas. And fibroids themselves, even when they're inside the uterus, can have a cystic appearance, meaning it has something inside of it, like fluid. It's not necessarily solid. And sometimes that happens because fibroids do what's called degenerate, and they can accumulate fluid and blood inside of them. Okay, Rosemary wants to know, because I am okay with not having children, I'm told I should remove everything but my ovaries. And I think that's the conversation that Dr. Datta-Thomas and I were just having. If the indication for the hysterectomy is a good, really good indication, you have so much pain, so much bleeding, you can't live with it anymore, you may have tried one or two other things, they don't work either. Then I certainly, if you're definitely going to have a hysterectomy, I certainly recommend, one, of course, have it laparoscopically. Don't have it any other way. There's no reason for that. But I also certainly recommend leaving the ovaries in. But remember, leaving the ovaries in doesn't mean leaving the fallopian tubes in. And make sure your doctor is also taking your fallopian tubes out. Why? Because fallopian tubes are implicated as the site of where early ovarian cancers can start. So even if you're at average risk for ovarian cancer, you should, if you're going to have a hysterectomy, the tubes should come out also. There's absolutely no reason to leave them in, which is something that just started about 10 years ago. So that was a great question. Let's see. So this is a question Good Samaritan asked about a hysterectomy with regard to fibroids and the potential, implications of having a hysterectomy with regard to uterine prolapse. I'm sorry, obviously the uterus is out, with regard to vaginal prolapse. Good Samaritan, you brought up a great topic. We don't have time for that topic today because it's about an hour-long conversation, but I would love to have it, and I think we'll do prolapse. It happens that we have an expert lined up for that very topic, but I think in the fall. So we will definitely get to that. It sounds like Rosemary's getting ready to have surgery, and we wish you the best of luck. I'm just writing a little note to fibroids. One of the big important topics that we like to try to get to with people is the topic of nutrition. And Paula, thank you for re-asking your question I'd like to kind of end with that because nutrition means so much, and I try to end all our conversations here with a little bit about nutrition because it's such an important educational topic. My first conversation on that is there's a lot of stuff out there about nutrition. I, for one, am in the camp that there isn't one single micronutrient, whether it's vitamin X, Y, or Z, or whatever, that treats or cures any disease. It's a combination of whole foods, healthy nutrition, and a holistic approach to the way your body responds to food. That's important. So when people ask me, "Oh, can this decrease, my chances of getting that?" Then I say, well, maybe that can be a contributing factor, but there are other things you have to pay attention to. Paula asked me specifically about calcium D-glucarate or iodine. Iodine in association with fibroids, I'm not particularly familiar with, but calcium, the calcium glucarate has been shown. So there are estrogen's not one thing. Estrogen is many, many different types of compounds, and there are a lot of estrogens in your body, a lot of different forms of estrogen in your body. And one of the types of estrogen that you take in is called, one of the categories of estrogens that you take in is called phytoestrogens. And so calcium D-glucarate probably, or the glucarates in general, probably bind phytoestrogens and decrease circulating phytoestrogens. The big estrogen in your body is called estradiol, and that calcium D-glucarate may not have such a big effect on estradiol. So it's probably a more complex conversation. But the conversation about some of these supplements that is important to understand is that once you stop them, just like any other medication, the effects are gone. The effects are only there while you're taking them. So from a long-term standpoint, it's not necessarily beneficial, which is why I tell people develop a healthy diet, develop something that includes these supplements potentially, but find foods that are rich in the things that will help you. Like the green tea is a great idea. Have a green tea every night. Fantastic. What a great way to fall asleep. And who falls asleep to tea? Is that just me? Well, what a great way to end the day. And green tea makes me feel happy and warm inside. So I'm going to end the conversation with green tea. Dr. Datta, do you have anything to add about anything associated with fibroids that we missed talking about? These were great questions from our YouTube audience. I don't think we've ever had so many awesome questions.
Yeah, this is great. This is great. And I think it just goes to show that, people are at least talking about it more. We're having Fibroid Awareness Month, which is great. And I think, there's a lot more information out there. I think techniques have really evolved. And I really always just urge my friends and family to have very open, candid discussions. Do your research. Information is out there, obviously, from good resources. And all of your options, because over time techniques change. You want to make sure, you may have to meet a few different people that are going to offer you different treatments, right? 3 different doctors, 4 different treatments. Sometimes they joke, but that is important because you want to know who has the right approach for you personally. These are very individualized plans that we need. And you need somebody that will really be open. I feel very fortunate that we have a group and we are constantly, staying up with changing standard of practice. And that's really important as a patient to make sure that your beliefs, what you're comfortable with, match your doctor, and that they have, again, a large box to offer you for treatment.
That is awesome. That is great. Thank you everyone for joining us again on a Friday morning, afternoon now, Women's Health Weekly, with the experts in women's health from Maiden Lane Medical, and today experts in fibroids and everything fibroids. And happy Fibroids Month. Please subscribe to our YouTube channel. Please join us on our podcast, which is completely available after this broadcast. And I wish everyone a warm, healthy, happy, and safe weekend. We look forward to talking to you. Actually, next week we'll be off. I am taking the family on an RV trip. Our first vacation in a very long time, as one might imagine. So we're going on a 4-day RV trip. And then the week after we'll be back, and we're off for all of August and then back in September. So one more episode, July 31st. We'll find something cool to talk about. It looks like weight loss. and then we'll go from there. All right. Have a great weekend, everybody. Bye-bye.